Hello, I'm presenting to you the Week 3 case study for Advanced Pharmacology. We are doing our case study on seizures in the elderly. I'm ECruzv2, the leader for this week. Group 2 consists of Nicole Cornish, Jared Dowhauer, and Claire Connor. So this is the case of Mrs. Valdez. Mrs. Valdez is a 70-year-old lady who comes in for evaluation for recurrences of loss of consciousness. Now, Mrs. Valdez's daughter is very concerned about her because she has been having episodes of stiffening, falling to the ground, and then shaking, and then afterwards she's confused for a few minutes. The daughter has been reporting these episodes occur 2 to 3 times a week, and on evaluation today, the patient's neuro exam is normal. Her blood pressure is a little elevated though at 190/90. Her medical history consists of hypercholesterolemia, hypertension, and anxiety. Family history: her brother developed seizures in the late 60s and then he suffered a stroke. The MRI today shows mild diffuse atrophy and white matter changes and small vessel ischemic disease. The EEG is normal, but the 24-hour ambulatory EEG shows multifocal epileptiform discharges, particularly in the right frontal region. Now here are some facts about seizures. About half to 1% of the population has epilepsy, and less than half of these cases have an identifiable cause. Some examples of identifiable causes are brain tumors, stroke, intracranial infection, cerebral degeneration, congenital brain malformations, errors of metabolism, and genetic factors. For Mrs. Valdez in particular, her major risk factor is hypertension, and we believe she suffered an ischemic stroke due to physiologic response to maintain brain perfusion. So now her hypertension has just been complicated by this new diagnosis of epilepsy. For monitoring and testing, patients with epilepsy activity should be monitored closely, especially during the initial phase and until etiology or provoking element has been found that's been causing the seizures. During this acute phase, it's important to protect the airway, and the patient should be cardiac rhythm monitored in the telemetry or ICU, along with termination of seizure activity. So they want to make sure that before they discharge her home that the seizure are under control or have stopped altogether. It's important to monitor vital signs, oxygen saturation, and labs such as CBC, electrolyte panel, blood glucose, toxicology, serum prolactin, and serum CK. After the initial treatment, lab testing should be ordered at 1 month following the therapy, and then at 3-month intervals, including CBC, liver function, and electrolyte panel. It's also important to discuss the pathophysiology of seizures to get a better understanding of what's happening with Mrs. Valdez. There's different types of seizures too. In particular, there's the general or focal seizures. General seizures, or generalized, consist of abnormal electrical discharges in both hemispheres. And then the focal is it begins in a localized area of the brain, and the clinical manifestations are reflected locally, but they can spread to cortical areas or transmit through different pathways, and then they can cause tonic-clonic seizures. Our patient in particular has the multifocal epileptiform discharges according to the EEG, so she has been having focal seizures in the frontal region of her brain. So basically, seizures occur when abnormal neurons have prolonged depolarization and rapid firing of action potentials. There is an imbalance between excitatory and inhibitory processes of the brain, and you can actually see this happening in the patients when they vacillate between the jerking and relaxation of a tonic-clonic seizure. So the mechanisms of generation come from abnormalities in the membrane properties of neurons, changes in the ionic microenvironment surrounding the neuron, decreased inhibitory neurotransmission, which is primarily by gamma-aminobutyric acid, and enhanced excitatory neurotransmission, which is primarily mediated by the acidic amino acid glutamate. Now, for Mrs. Valdez, it's important to consider drugs in the elderly, how they affect the elderly, because The geriatric population is very different from younger adults and middle-aged individuals. There are special considerations that have to be taken into account. Elderly have decreased plasma proteins and albumins, and this lowers the protein binding of medication, increasing the risk for toxic symptoms. Drug metabolism is also altered by increased fat to lean body mass, decreased liver function, decreased gastric mobility, and increased gastric pH. So therefore, since the elderly are more likely to have side effects, monotherapy is the preferred type of therapy for this group. The dose is going to be started low and titrated up to reduce the risk for side effects. Mrs. Valdez will be started on lamotrigine, or Lamictal. We're going to start her at 25 milligrams PO daily for 2 weeks, and we'll titrate up as needed to a max dose of 200 milligrams per day. We'll go up 25, 50, 100 to 200. If she can tolerate it, we'll see how she does with the therapy. Here's some facts about lamotrigine. It works by blocking the repetitive firing of neurons by inactivating voltage-dependent sodium channels. It decreases excitatory neurotransmitters glutamate and aspartate. It's only 55% bound to plasma. It's metabolized by the liver and excreted in the urine. There's a reason we chose Lamictal. There's been a lot of evidence that shows that newer anti-epileptic drugs, or AEDs, are better for the elderly population. In one study we found, it was a prospective observational study. It lasted 1 year. There were 222 patients enrolled and 132 completed the study. 89% of these individuals remained seizure-free for 1 whole year, and that's clinically significant for the elderly population. Only about 8 or 9 experienced adverse drug reactions, and 2 of them developed a rash, but overall, statistically significant, great results for the elderly. Other studies have shown that the first generation AEDs might not be appropriate for the elderly. They have a harmful impact on functional recovery and bone health. Some of these drugs are actually implicated in causing osteoporosis. There's increased interaction with anticoagulants and salicylates. There's lack of level A evidence to use the first generation AEDs. 2 drugs that we found that were first generation that wouldn't work well would be valproate. You'd want to avoid this in using the elderly because it's too highly protein bound, which could cause increased risk for adverse drug reactions. And then oxcarbazepine, which could cause low sodium or hyponatremia in elderly patients. Now, for Mrs. Valdez and her daughter, we would have to tell them or educate them about this drug. They should notify the provider of any rash, fever, or swollen lymph glands that might develop. It might cause dizziness, drowsiness, and blurred vision, so she shouldn't drive. Well, regardless of what drug she's taking, she's a seizure patient, so she shouldn't drive at all unless or until the physician or provider clears her to drive. This drug causes photosensitivity, so it's important to wear sunscreen. And lab tests may be required to ensure therapeutic range for her, which is 1 to 5 micrograms per milliliter. So this is the end of our case study, and here are references.